I've been working as an EMT for almost 7 years now, and I thought I'd seen everything. Overdoses, car accidents, heart attacks, strokes, domestic violence calls, suicide attempts. You name it, I've probably worked it. This job hardens you pretty quick. You learn to compartmentalize, to focus on the medical protocols, and push the emotional stuff down until later. If you don't, you'll burn out within your first year. But there's one call that happened about 2 years ago that I still can't get out of my head. I've debated writing about this for months because honestly, I'm not sure anyone would believe it. Even my partner from that night, Rodriguez, transferred to a different unit not long after, and we've never really talked about what happened. I think he's trying to forget it, and maybe I should too, but I can't. It was a Thursday night in early November, around 3:15 a.m. We'd been having one of those brutal shifts where the calls just kept coming. 2 MVCS, a cardiac arrest that we couldn't get back, a domestic violence call that got ugly, and a psych patient who'd been off his meds for weeks. By the time we finally got a break, we were both exhausted and running on gas station coffee and spite. We were parked outside a 24-hour diner, trying to stay awake and catch up on our paperwork, when dispatch came through with a priority 2 call. 57-year-old male, difficulty breathing, conscious and alert. The address was in Millbrook Heights, one of those middle-class neighborhoods with tree-lined streets and houses that all look pretty much the same. As we pulled up to the address, I noticed the house was completely dark except for one light in what looked like the front window. There was a sedan in the driveway and the yard was well maintained, nothing out of the ordinary. A woman met us at the front door before we could knock. She looked to be in her early 50s, wearing a nightgown and robe, her graying hair pulled back in a ponytail. "Thank you for coming," she said, stepping aside to let us in. "It's my husband, Robert. He's been having trouble breathing for the past hour. He says his chest feels tight." Rodriguez grabbed our gear while I wheeled in the stretcher. The house was typical suburban layout, clean and organized, with family photos on the walls and the kind of furniture you see in department store catalogs. The woman led us into the living room where a man was sitting on the edge of the couch, leaning forward with his elbows on his knees. My first impression was that he looked genuinely distressed. He was a big guy, probably 6 feet tall and maybe 250 pounds, with thinning gray hair and wire-rimmed glasses. He was wearing pajama pants and a t-shirt, and he was clearly having trouble breathing. His respiratory rate was elevated, maybe 24 or 26 breaths per minute, and he was using accessory muscles in his neck and shoulders. "Robert," I said, kneeling down in front of him. "I'm Jake. I'm a paramedic. Can you tell me what's going on?" He looked up at me, and I could see the fear in his eyes. I can't catch my breath," he said between gasps. "Started about an hour ago, just came out of nowhere." I began my assessment while Rodriguez set up our equipment. Robert's pulse was elevated, around 110 beats per minute, but strong and regular. His blood pressure was slightly high at 160/90, which wasn't unusual for someone in respiratory distress. What concerned me was his oxygen saturation, which was reading 88% on room air. "Any chest pain?" I asked while Rodriguez put him on oxygen. "Some," Robert said. "Not sharp, just heavy, like someone sitting on my chest." His wife hovered nearby, wringing her hands. Should I have called sooner? I kept thinking it would pass, but it just kept getting worse. "You did the right thing," I told her. "Robert, any history of heart problems? Asthma, COPD? He shook his head. "Nothing like that. I'm pretty healthy. Had a physical 3 months ago, everything was normal." We got Robert on high-flow oxygen and started an IV. His oxygen saturation improved slightly to 91%, but he was still working hard to breathe. Everything about his presentation suggested either a cardiac event or a pulmonary embolism, both of which required immediate transport to the hospital. As we were preparing to move him to the stretcher, I noticed something odd. Despite his obvious respiratory distress, Robert's skin color looked normal. Usually, when someone's having trouble breathing and their oxygen levels are low, you'll see some cyanosis around the lips and fingernails. But Robert looked pink and healthy, which didn't match his symptoms or his oxygen readings. "Any recent surgeries, long flights, periods of immobility?" I asked, thinking about risk factors for blood clots. "No, nothing like that," his wife answered. "He's been working in the yard all week, very active." We loaded Robert onto our stretcher and headed for the ambulance. His wife said she'd follow us to the hospital. During transport, I continued monitoring his vitals and oxygen levels. The strange thing was, despite being on high-flow oxygen, his saturation wasn't improving much. It fluctuated between 89 and 92%, which was concerning. But what really started to bother me was something I couldn't quite put my finger on. Robert continued to show all the signs of severe respiratory distress, but there was something about it that felt off. I've seen hundreds of patients in respiratory distress, and there's usually a certain desperation, a panic that comes with not being able to breathe properly. Robert seemed distressed, but in a controlled way, like he was performing the symptoms rather than experiencing them. "How's the breathing now?" I asked him about halfway to the hospital. "Still bad," he said, but his voice was stronger than it had been at the house. "The oxygen helps a little." Rodriguez was driving, but I could see him glancing in the rearview mirror at our patient. We'd worked together for almost 2 years, and I could tell when something was bothering him. At the hospital, we transferred Robert to the emergency department and gave our report to the receiving nurse. 57-year-old male with acute onset respiratory distress, oxygen saturation in the high 80s to low 90s on high-flow oxygen, possible cardiac or pulmonary etiology. The ED team took over, and we restocked our ambulance and cleared for the next call. Rodriguez was unusually quiet as we drove away from the hospital. Finally, he said, "There was something weird about that call." "What do you mean?" "I don't know, man. Something about the whole situation just felt off." "Did you notice how calm his wife was?" Now that he mentioned it, I had noticed that. Most spouses of patients in respiratory distress are frantic, asking a million questions, getting in the way. Robert's wife had been concerned, but in a distant sort of way, like she was watching a movie rather than living through a medical emergency with her husband. "And did you see how clean the house was?" Rodriguez continued. "I mean, it's 3 in the morning. Her husband's having a medical emergency, but the place looked like it was ready for a magazine photo shoot." He was right. Most houses we go into at 3 a.m. are lived in, with dishes in the sink, clothes on chairs, the normal clutter of daily life. Robert and his wife's house had looked pristine, almost staged. "Maybe they're just neat people," I said, but even as I said it, I didn't believe it. "Maybe," Rodriguez said, but he didn't sound convinced either. We didn't get another call for about an hour, so we parked at our usual spot and tried to grab some rest. But I couldn't stop thinking about Robert and his wife. Something about the whole situation had felt rehearsed, like they were both playing roles rather than dealing with a genuine medical emergency. About a week later, I was back at the hospital dropping off a cardiac patient when I ran into Dr. Patel, one of the emergency physicians I'd worked with many times. He was coming out of the break room with a coffee, looking tired but alert. "Hey, Jake," he said. "Quick question about a patient you brought in last week. Middle-aged guy, respiratory distress, last name Fletcher." "Yeah, I remember him. What about it?" Dr. Patel looked around the hallway, then pulled me aside. "Did anything about that call seem strange to you?" I felt my stomach tighten. "Why do you ask?" "Well, we worked him up pretty thoroughly. Chest x-ray, CT angiogram, blood gases, the whole protocol for respiratory distress. Everything came back completely normal." "That's good, right? Means it wasn't a heart attack or blood clots." "That's just it," Dr. Patel said. "We couldn't find anything wrong with him. His chest x-ray was clear, his EKG was normal, his blood work was perfect, but he continued to show signs of respiratory distress for about 4 hours after you brought him in." "What happened then?" "He just got better. Said he was feeling fine, wanted to go home. We kept him for observation for another few hours, then discharged him with instructions to follow up with his primary care doctor if symptoms returned." I thought about this for a moment. Maybe it was anxiety. panic attack? That's what we thought at first. But panic attacks usually respond to reassurance and anxiolytics. This guy didn't improve until he just decided to, I guess. Dr. Patel looked uncomfortable, like he was debating whether to say something else. "What is it?" I asked. "I called his primary care physician to follow up yesterday. Wanted to make sure everything was okay, that there weren't any underlying issues we'd missed. And the doctor said Robert Fletcher wasn't his patient. In fact, he'd never heard of Robert Fletcher at all. So I checked our registration system, thinking maybe there was a mistake with the insurance information." My mouth felt dry. "What did you find?" "The insurance card Robert gave us was fake. The policy number doesn't exist, and when I called the phone number he provided, it was disconnected." I stared at Dr. Patel, trying to process what he was telling me. That doesn't make sense. Why would someone fake a medical emergency? "I have no idea, but there's more. I drove by the address you responded to yesterday, just out of curiosity." "What did you find?" "The house has been for sale for 6 months. It's empty. The realtor said the previous owners moved out last spring, and it's been vacant since then." I felt cold. "That's impossible. We were in that house. We talked to his wife." I know how this sounds, but I called the listing agent and asked about the previous owners. The house was owned by an elderly couple, the Hendersons. They moved to Florida to be closer to their daughter. No one named Fletcher has ever lived there. Neither of us spoke for several minutes. Finally, I asked, "What do you think happened?" Dr. Patel shrugged. "I honestly don't know. Maybe it was some kind of insurance fraud attempt, although that doesn't explain why he gave us a fake insurance card. Maybe it was a mental health issue, some kind of elaborate delusion. But his wife seemed real enough, and delusions usually don't involve other people." I left the hospital that day feeling deeply unsettled. That night, I called Rodriguez and told him about my conversation with Dr. Patel. "I knew something was wrong with that call," he said. "The whole time we were there, I felt like I was in some kind of play, like everyone was reading from a script." "Did you notice anything else that seemed off?" Rodriguez was quiet for a moment. "Yeah, actually. When we were loading the guy into the ambulance, I looked back at the house. The wife was standing in the doorway watching us, but there was something weird about the way she was standing. She was completely motionless, like a statue, and she stayed in that exact position until we drove away." "People react differently to stress," I said, but even as I said it, I knew it was a weak explanation. "Also," Rodriguez continued, "did you notice that we never saw any other signs of life in that house? No dirty dishes, no newspapers, no personal belongings sitting around. It was like a model home." He was right. The house had felt empty despite being furnished. There hadn't been any of the small details that make a place feel lived in. Over the next few weeks, I found myself thinking about Robert Fletcher constantly. I drove by the house one afternoon, and sure enough, there was a realtor's sign in the front yard. The grass was getting long, and there were leaves piling up on the driveway. It clearly hadn't been occupied in months, but as I sat in my car looking at the house, I could have sworn I saw movement in the front window, the same window where we'd seen the light that night. Just a shadow, like someone walking past, but it was enough to make me drive away quickly. About 3 months later, we got another call to the same neighborhood, different street, but close enough that we had to drive past the Fletcher house. The realtor's sign was still there, but now it had a price-reduced sticker on it. This new call was for a 62-year-old woman with chest pain. Same time of night, around 3 a.m. Same setup, house mostly dark with one light on, family member meeting us at the door, patient sitting in the living room in obvious distress. The woman, who said her name was Dorothy Walsh, was having classic chest pain symptoms, pressure in the center of her chest, radiating to her left arm, accompanied by nausea and shortness of breath. Her vital signs were consistent with a cardiac event: elevated heart rate, slightly elevated blood pressure, oxygen saturation in the low 90s. Her daughter, who'd called 911, was appropriately anxious but composed. She gave us a clear history. Her mother had been fine all day, then complained of chest pain while watching television. The pain had been getting progressively worse for about an hour before they called us. Everything about the call seemed normal and appropriate. We transported Dorothy to the hospital, where she was admitted for observation and cardiac workup. Her daughter followed us in her car, and I assumed that would be the end of it. But 3 days later, I was at the hospital again and ran into Dr. Patel in the cafeteria. "That chest pain patient you brought in Thursday night," he said without preamble. "Dorothy Walsh." I felt my stomach drop. "What about her?" "Same thing. Completely normal workup. EKG, chest x-ray, cardiac enzymes, everything came back normal. She was fine by morning and wanted to go home." "Heart attacks can be tricky in women," I said. "Sometimes the symptoms are atypical." That's what we thought. But when I tried to follow up with her primary care physician, same thing as before. No record of Dorothy Walsh as a patient. And when I called the phone number she gave us, it was disconnected. I sat down heavily in one of the cafeteria chairs. "Please tell me you didn't drive by the house." I did. Same story. House has been empty for 8 months, for sale by a different realtor. "This is insane," I said. "Who are these people? What do they want?" Dr. Patel sat down across from me. "I've been thinking about that. What if they're not trying to scam the system or fake illnesses for drugs? What if they genuinely believe they're sick?" "You mean like mass hysteria or something?" "I don't know. Maybe some kind of shared delusion. Or maybe there's something environmental in that neighborhood that's making people think they're having medical emergencies." It was a reasonable theory, but it didn't explain the empty houses or the fake identities. Over the next few months, we responded to 4 more calls in that same general area. Always the same pattern. Middle-aged or elderly patients with acute but ultimately unexplainable symptoms, presented in houses that turned out to be empty, with family members who disappeared without a trace. Rodriguez requested a transfer after the 3rd case. He said he couldn't handle the uncertainty, the feeling that we were being manipulated somehow. I understood his decision, but part of me felt like I needed to stay and figure out what was happening. My new partner, Anderson, is younger and less experienced. When I tried to warn him about the strange calls in that neighborhood, he looked at me like I was losing my mind. Maybe I am. But when we got another call there last month, I paid closer attention to details than I had before. The patient was a 70-year-old man named Eugene Davies, complaining of severe abdominal pain. His son had called 911, saying his father had been fine earlier in the evening, but suddenly doubled over in pain while they were watching the news. Eugene was clearly in distress, curled up on his side on the living room couch, moaning softly. His vital signs were elevated but stable, and he had tenderness in his lower right quadrant that suggested possible appendicitis. Everything about his presentation seemed legitimate. But as we were treating him, I started noticing things that bothered me. The house was immaculate, not a thing out of place. There were no personal items visible anywhere, no family photos, no mail on the counter, nothing to suggest people actually lived there. The refrigerator was empty, except for a few generic items that looked like they'd been placed there for show. Eugene's son was appropriately concerned, but when I asked him about his father's medical history, he gave vague answers. No regular medications, no known allergies, no recent surgeries. When I asked for the name of Eugene's primary care physician, he said he wasn't sure, that his father handled his own medical affairs. During transport, Eugene continued to show signs of pain, but there was something performative about it. I've seen hundreds of patients with abdominal pain, and there's usually a specific way they position themselves, specific responses to palpation. Eugene's reactions seemed slightly off, like he was trying to remember how someone in pain should act. At the hospital, Anderson and I gave our report and transferred care to the ED team. As we were leaving, I made a point of memorizing Eugene's son's license plate number from the parking lot. The next day, I ran the plate through a friend who works in dispatch. The car was registered to someone who died 3 years ago. That night, I couldn't sleep. I kept thinking about all these calls, all these people who appeared out of nowhere with medical emergencies, then vanished like they'd never existed. I started wondering if there was some kind of pattern I was missing, some connection between the patients or the locations. I pulled out all my old run sheets from calls in that neighborhood and spread them out on my kitchen table. 7 calls over 8 months, all between 2 a.m. and 4 a.m., all to houses that turned out to be empty. The patients ranged in age from 47 to 73, both men and women with various medical complaints. But as I looked at the addresses, I noticed something interesting. They formed a rough circle around a central point, about a 6-block area. I pulled up a map online and plotted all the locations. The center of the circle was occupied by an old church that had been abandoned for several years. I'd driven past St. Margaret's Catholic Church dozens of times over the years. It was a brick building from the 1920s with a tall steeple and stained glass windows that were now boarded up. The parking lot was cracked and overgrown with weeds, and there was a chain-link fence around the property with no trespassing signs. The next afternoon, I drove by the church during daylight. It looked exactly as I remembered it, abandoned, neglected, with no signs of recent activity. But as I was sitting in my car across the street, I noticed something that made my blood run cold. There were fresh tire tracks in the church parking lot, recent enough that they couldn't have been there long, leading from the street to the back of the building where I couldn't see. I sat there for about 20 minutes, debating whether to investigate further or just drive away and pretend I'd never noticed the tire tracks. In the end, curiosity won out. I parked my car down the street and walked back to the church. The main entrance was chained shut, but there was a side door near the back of the building that was slightly ajar. I could hear voices coming from inside, low and indistinct, like people having a quiet conversation. I pushed the door open slowly and stepped inside. The church was dark, except for some candles burning near the altar. There were about a dozen people sitting in the pews, all facing forward, all completely motionless. I recognized some of them immediately. Robert Fletcher and his wife, Dorothy Walsh, and her daughter, Eugene Davies, and his son. They were just sitting there in silence, staring at the altar where someone had placed dozens of medical textbooks and equipment. Stethoscopes, blood pressure cuffs, oxygen masks, even what looked like a stretcher. I stood in the doorway, not sure what to do. These people had called 911, had been transported to hospitals, had been examined by doctors. But here they were, gathered in an abandoned church like they were attending some kind of bizarre medical service. After about 10 minutes, they all stood up in unison and began filing out through a door behind the altar. None of them looked in my direction. None of them spoke. They moved like sleepwalkers, slow and deliberate. I waited until they were gone, then approached the altar to get a better look at the medical equipment. It was all real, all functional, but arranged in a ritualistic way that made no sense. The textbooks were opened to pages about emergency medicine, trauma care, cardiac procedures. In the center of the arrangement was a notebook filled with handwritten entries. I opened it and found detailed descriptions of medical emergencies, complete with symptoms, vital signs, and treatment protocols. It was like a study guide for faking medical conditions. I heard footsteps behind me and turned around to find Eugene Davies standing in the aisle, looking directly at me. "You shouldn't be here," he said, his voice calm and measured. "What is this place?" I asked. "What are you people doing?" "We're practicing," he said, like it was the most natural thing in the world. "Practicing for what?" Eugene smiled, but it didn't reach his eyes. "For when it's real." Before I could ask what he meant, he turned and walked away, disappearing through the same door the others had used. I was left alone in the abandoned church, surrounded by medical equipment and textbooks, trying to make sense of what I'd witnessed. I left quickly and drove straight home, but I couldn't stop thinking about Eugene's words. For when it's real. What did that mean? Were they preparing for some kind of mass casualty event? Were they planning to hurt themselves or others? I considered calling the police, but what would I tell them? That I'd found a group of people studying medical textbooks in an abandoned church? That they'd been faking medical emergencies? It sounded insane even to me. 2 weeks later, we got another call in that neighborhood. This time, it was a real emergency, a house fire with multiple victims. When we arrived, I recognized the address immediately. It was Robert Fletcher's house, the one that had supposedly been empty for months. The fire department was already on scene, and they'd pulled 3 people from the burning building: an elderly man with severe burns and smoke inhalation, a middle-aged woman who was unconscious but breathing, and a younger man who was alert but in shock. As I worked on the elderly man, trying to establish an airway and start fluids, I realized I recognized him. It was Eugene Davies, the man I'd encountered in the church. But this time, his medical emergency was real. His burns were genuine. His respiratory distress was authentic. His pain was unmistakable. As we loaded him into the ambulance, he grabbed my arm with surprising strength. "We were ready," he whispered, his voice barely audible over the sound of the sirens. "When it was real, we were ready." He died on the way to the hospital despite our best efforts. The woman and the younger man survived with injuries, but when the hospital tried to contact their families, they discovered that neither of them existed in any official records. No social security numbers, no driver's licenses, no medical histories. The fire investigation concluded that the blaze had been caused by faulty electrical wiring in the abandoned house. But the investigators couldn't explain how 3 people had been living in a building that had been vacant for months, or why there was no evidence of recent habitation beyond the victims themselves. I never found out who those people really were, or why they'd been faking medical emergencies for months. I never discovered what they were practicing for, or how they'd managed to live invisible lives without leaving any traces in the system. But I think about Eugene's final words constantly. When it was real, we were ready. Maybe that was the point all along. Maybe they were people who'd been forgotten by society, who'd fallen through the cracks of the system, and faking medical emergencies was their way of staying connected to the world, of preparing for the day when they'd need help for real. Or maybe there's a simpler explanation that I'm missing, some logical reason for everything I witnessed. But deep down, I don't think so. Sometimes people disappear from the world while they're still alive, and sometimes they spend their remaining time practicing how to be found again. I still work that neighborhood, and I still respond to medical emergencies at all hours of the night. But now I pay closer attention to the details, to the small signs that something might not be what it appears. Because I've learned that reality is more fragile than we like to believe, and that sometimes the line between genuine crisis and elaborate performance is thinner than we think. And every time I see an abandoned building or an empty house, I wonder who might be hiding inside, studying medical textbooks by candlelight, preparing for the day when their practice becomes reality.